I am presenting case under the moderation of Ankit Parak sir, Senior Consultant Pediatric Pulmonology, BLK Max Super Specialty Hospital. Dr. Suresh Gupta sir, Co-Chairman, Department of Pediatrics, Co-Director, Pediatric Emergency Intensive Care, Gangaram Hospital, Delhi. And Antar Bhai Patel sir, IAP Fellow, Division of Pediatric Pulmonology and Allergy, Institute of Child Health, New Delhi. My patient name ABC, age of 8 years, male, sex male, resident of Sitapur, UP, informant by mother, which is reliable, perceived in emergency, with a chief complaint of cough since 1 day and difficulty in breathing since 1 day. History of presenting complaints, child was apparently all right 1 day ago when he started with dry cough for 1 day, sudden in onset, progressively increased at night time and daytime, decreasing on taking nebulization with particular medicine at home with no postural variation. Child had history of difficulty in breathing for 1 day, which was present even at rest, increasing even doing daily physical activity, and was associated with chest tightness. As per the mother, child had difficulty completing sentence but could speak in single words. History of the presenting complaint, there was no associated postural or diurnal variations, and distress settled on taking nebulization at home. No history of fever, no history of irritability, lethargy, no history of chest pain, abdominal pain, no history of choking sensation or cyanosis, no history of altered sensorium, no history of recurrent sneezing, rhinorrhea, and no history of skin rash. Past history of child had history of similar complaints 2 to 3 times this year following a change in weather and was admitted on such occasions. No PICU requirement at that time. Child had history of coughing at night after sleep and with seasonal changes. Child had similar complaint 2 years back. Also for that, he was admitted in nearby hospital in ward. No ventilator support required. And child was kept on oxygen by mask and cough relieved with nebulization. He was prescribed medications in the form of inhaler as a single puff to be taken twice daily without any spacer, but child was not compliant. Should I proceed, sir? There is history suggestive of asthma in grandfather, for which he was on Rotacap inhaler. No history of skin allergy or allergic rhinitis in family. This is pedigree chart showing the child is 8-year age. Birth history. The baby was born preterm at 25 years old, primary gravida, mother in a hospital at 35 to 3 gestational age.
Dr. Antar there?
Yes, sir. Yes, sir.
Achha, just keep on asking the relevant question in between the history also.
Okay, sir. Okay, sir. So,
whatever they are missing in the history or examination.
Okay, sir. Okay,
from
sir.
DNB point of view.
Okay, sir. Dr. Arun, so can you summarize your history and tell me the positive findings from your history?
So, child have cough and difficulty breathing on 1 day. Cough is dry in nature, progressively increased at night time with breathing difficulty and increasing doing daily activity associated with chest tightness and child had difficulty completing sentences, could speak in single words with no postural variations and distress lived on taking nebulization at home.
So,
and
that we understood. So my question is, what are your differential after taking initial history?
So differentials after taking history may be due to the obstruction in our airway, upper airway, or due to any upper respiratory due to cough due to upper respiratory tract infection, or due to the asthma according to history.
Okay, why you said upper airway obstruction?
Sir, but it is most probable asthma, not the upper airway obstruction, because there is no laryngomalacia or no any other symptoms related to it. And for foreign body, as according to history, there is no breathing difficult with breathing difficult, no noisy breathing.
So again, reorganize your thoughts and give me one or two differentials.
Sir, sir, asthma.
Okay, if you are saying asthma, what is in favor of asthma from your history and what is against asthma in your history?
Sir, in favor of in the favor of the child has breathing difficulty with which is increased on daily doing activity, and child having chest tightness, and child has no postural variations.
So if there are postural, you have written there are no diarrheal variation. Asthma, there is always variability of symptoms in the period of time. So that
Yes, sir.
is your diagnosis of asthma. Only
Okay,
thing
sir.
you could see in this child is you have written that distress improved after taking nebulization at home. Most probably short-acting beta-2 agonist. So there you are assuming that it can be asthma. Okay, suppose you have made a diagnosis of asthma, but from your history, can you quantify the severity of this asthma?
Sir, if child has a severity, sir, if it is severity on the basis of comorbidity associated with asthma or other else.
No, I'm saying whether this is just partially controlled asthma, uncontrolled asthma, well-controlled asthma, it fits in which category, if at all, this diagnosis of asthma, and does it fits in the diagnosis of exacerbation of asthma?
Sir, this is the partially controlled asthma.
Okay. So previously, child was on any inhaled medications? Any past history of any past drug history is there?
Yeah, sir. Child is on nebulization on metadol inhaler, sir.
Which metador inhaler child was taking? Anything they have specified?
So no specified. So no specification given by mother.
So it's still not clear whether it was, first of all, asthma or not. And second, it's partial controlled or poorly controlled asthma. That is not clear, right?
Okay, sir.
Okay. Why you have taken history of previous ventilation and all these things? What are you trying to find out?
Sir, I want to find out the severity of asthma or episodes, because if child having a previous episodes of asthma and he was required for ventilation, then it is severe asthma. If child is not required any ventilation, only treated on the OPD basis or ward basis with only oxygen or nebulization, then it may comes in the partial or partial controlled asthma.
Okay, 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 go ahead.
Sir, from negative history or from
Past history is over. Now go ahead.
family history? There is history of suggestive asthma in grandfather, for which he was on rota cap inhaler, and no history of skin allergy or allergic rhinitis in family. Birth history: baby was born preterm to a 25-year-old primary gave mother in a hospital at 35 plus 3 weeks of gestation age. The baby was born vaginally with birth weight of 3 kg, and child cried immediately after birth with no NICU admission. Development history: child attained all age appropriate milestones. Currently, child is in 2nd class and is good at academics as per the mother. Immunization history: child is up to date immunized as per mother. No official record available. As per immunization schedule, child was, as mother told, as child immunized up to date. Dietary history, total calorie requirement is 1700 kilocalorie and protein requirement is 19 kilocalorie, but child consumed 1029 kilocalorie, deficient by 40%, and total protein consumed 22 gram, deficient protein excess by 13%. Socioeconomic history-wise, child has joined family of total 5 members, 4 adults, including grandmother, grandfather, mother, father, and 1 child. Father is lawyer by professions, mother is school teacher, and father is head. This is chart showing modified Kupuswami scale. According to we have identify the status of the family, and family live in Pakka house having 1 floor with 3 bedrooms, 3 toilets, and 1 kitchen. All the rooms are adequately ventilated with windows. Family uses RO water for drinking and municipal water supply for rest of other activities. Grandmother is a religious woman with history of daily incense stick burning in the evening. None of the parents smoke, no pet at home. Summary wise, child is 8-year male, child with chronic respiratory disease, non-compliant to prescribed medications, came with sudden onset cough with respiratory distress for 1 day, which was leased on nebulization. He had 3 such similar episodes this year, mainly in winter season, 2 of which required admissions and no ventilation required at that time. The grandmother has history of asthma along with history of environmental allergic triggers at home.
Okay, Arun. So your probable diagnosis after history is asthma, right? The first
Okay,
probable differential will be asthma. So would you like to comment more about asthma, or it's just a simple case of asthma?
So the
Because
so
you were told that there is a history of sudden onset of cough, there is poor compliance. So what do you feel?
sir, acute exacerbations of asthma, sir.
So what is acute flare-up or acute exacerbation of asthma? How do you define that? What all things should be there to diagnose the patient as acute exacerbation?
Sir, acute exacerbation asthma, when we said acute exacerbation, some child having hyper-responsive inflammatory response, which is not
No, that is asthma
respond.
you are talking about. I am saying about asthma flare-ups. So asthma flare-ups, there has to be 2 things. One is first is worsening of symptoms, and second is worsening of lung function. So there are 4 cardinal symptoms of asthma. That is cough, shortness of breath, chest tightness,
Chest tightness.
and wheezing. So any worsening in these 4 symptoms associated with fall in peak expiratory flow or FEV1. That is your definition of acute asthma or exacerbation of asthma or asthma flare-ups. These all terminologies are interchangeably used. Okay, go ahead.
Differential diagnosis, acute severe asthma, acute viral pneumonia, foreign body aspirations. General physical examinations, child is anxious, pink color, tachypnea present with chest restrictions. Child is malnourished, overweight, anxious, temperature 98°/2 measured in right axilla. Pulse is 130, which is more, regular, good volume, no radial femoral or femoral delay. All peripheral pulses are palpable. Respiratory rate is 50 per minute, abdominothoracic. SpO2 89% at room air, and after the oxygen it was 94, 95, between the 94 to 95%. Capillary filling time is less than 3 seconds. Peripherals are warm. Child is paler, presence. No other icterus, clubbing, cyanosis, or edema present at that time. No significant lymphadenopathy. General physical examination. According to hairs, good volume, and hairs are good volume and textures. Eyes are conjunctival pallor seen. Cornea sclera abnormal. Ear normal, nose normal. Oral cavity tonsils not enlarged, no midline bulge. Skin normal color, BCG scar marks present, thorax retractions present bilaterally. Anthropometry wise, child having weight 38 kg, it is more than 95th centiles, length is 124, 50 lies in 50th centile, and basal metamolarity is 24.7 kilogram per meter square, obese. And systemic, should I proceed, sir?
Go ahead.
Systemic examination, respiratory system inspection is our respiration rate is 50 per minute, bilateral hemithorax expansion equal, symmetrical hemithorax, nasal flaring with intercostal retractions, palpations, no tenderness, trachea central in position, and symmetrical expansion of both hemithorax. On auscultation, air entry decreased bilaterally in all lung area, bilateral inspiratory and expiratory wheezing in all area of lung. No crepitations were heard. Other systemic examination, abdominal examination, soft, non-tender, no hepatosplenomegaly with normal bowel sounds. CVS and CNS normal findings. And summary, 8-year male child with chronic respiratory disease, non-compliant to medication, sudden onset of cough, respiratory distress for 1 day, which are relieved on nebulization, having bilateral air entry decreased with bilateral inspiratory and expiratory wheezing. He had 3 similar episodes in this year, mainly winter season, 2 of required admissions, with grandmother history of asthma with environmental allergic triggers at home.
Okay. So, Arun, from here, can you assess the severity of exacerbation? So, more or less, our diagnosis is clear that it looks like more of acute exacerbation of asthma. So, can you assess the severity from your physical finding?
Yes, sir. Child is moderate, child have moderate intermediate severe asthma, sir.
So my question is, you have made a diagnosis of acute asthma, right? So
Yes, sir.
it can be divided in 3 categories. Because it's more than 6 years of age, it can be divided in mild to moderate, severe, or life-threatening exacerbation.
So
Okay.
this according to history,
This child
my
fits in which
child
category? Why you are saying that?
mild to moderate category child comes in mild to moderate category.
Why you are saying that?
Sir, because child. No, sorry, sir. Child is lies in severe category because child is bowling canned words, and child having respiratory rate increased with the pulse rate increasing pulse rate, and SpO2 is less than 90%. That's
Good.
why child lies in severe asthma.
So your child comes in a category of severe exacerbation. Okay.
Yes, sir.
Can you just enumerate the criteria for severe exacerbation? Or you want my help?
Yeah, sir. You
Okay.
can.
So,
Right.
if you want to categorize mild to moderate, severe, and life-threatening. So, if child is drowsy, confused, or silent chest, it is called labeled as life-threatening asthma. That patient directly goes to PHU, and during transport, you have to give short-acting beta-2 agonist, ipratoromal bromide, oxygen, and systemic corticosteroids. If you want to specify between mild to moderate and severe, you have to see few things. First is CNS should be normal. Second is speech. Child should be able to speak few words. Then it goes in severe asthma. If it speaks few phrases, then you have to see the position. If child is just hunched forward position, agitated, then it goes in favor of severe asthma. If your respiratory rate is more than 30, pulse rate more than 120, use of accessory muscles, SpO2 less than 90, and peak expiratory flow is less than or equal to 50% of the predicted, they are goes in category of severe asthma exacerbation. Rest all are in mild to moderate category. Okay, Arun. Then, so what is your next plan for this child?
Sir, according to asthma severity score, I will assess the child, and as I already told you, the uh, the child is in severe asthma because child had higher respiration rate greater than 120 pulse rate, and
Okay.
child saying words only.
We have done. Go ahead. Go ahead.
So should I proceed according to my
Yeah,
slides,
yeah.
sir?
Already we have diagnosed this as a severe exacerbation. Now, how
Yes, sir.
you are going to manage this child?
Sir, I will see. That's okay. Uh, Sir, should I discuss these slides or I will
Yeah,
directly?
discuss. No issues. Go ahead, discuss.
Sir, and we will see, sir, Becker's scores, but if the respiration rate is less than 30 or no wheezing and inspiratory aspiratory is 1:1:5, then no accessory muscles use. And score is respiration rate is lies in 30 to 40 with terminal expirations with IR ratio 1.2 and one site accessory muscle used. And if Baker score is 2, if it respiration rate is lies between the 41 to 50 with entire expirations with 1:3 ratio IE ratio with 2 accessory muscles used, and Baker's severity score is 3, and if their respiration rate is greater than 50 and inspiration entire expirations and 1:3 and 3 sides or neck strap muscles. And according to our patient, the respiration rate is greater than 50, around 50, and inspiration and expirations wheezing presence. So maybe lies in Baker's scores is 3. And with IAP pulmonary severity score, if respiration rate is our child is greater than 6 years, that's why the respiration I will discuss. And if score is 0, if respiration rate is less than 20 or no wheezing, no retractions, and a 1 if less than 21 to 35 terminal, same, that is almost same. And IAP score is 3 if greater than 50 respiration rate and with inspiration, expiration, wheezing, and without stethoscope and maximum use of accessory muscles. And respiration rate is in 50 and expiratory 3 score, restriction 2 side 2 scores, and inspiratory expiratory 1:2 ratio 9 scores. After the giving nebulization, respiratory ratio was become 36 with 1 score, wheezing entire, restriction 1 side presence, and inspiratory expiratory is 1:2. Then child scores was 5. And so should I proceed, sir?
Yeah, go ahead.
And the asthma management cycle punchlines depends upon the lies on behalf of the assessment, adjustment, and review. And on assessment, we will confirm the diagnosis as already we done, symptom control, modifiable risk factor, and comorbidities if there are any present, like obesity is present in my case, and inhaler technique and adherence as child is not adherent to proper inhaler technique and not taking medications, and patient preference goal. After that after assessment, we will adjust the treatment or dose according to the patient symptom, either patient symptoms increased or decreased or we controlled. Treatment of modifiable risk factors and comorbidities, non-pharmacological strategies, like we can use strategy like removing pets or any smoke history, we can bear about that, and asthma medication including inhaled corticosteroids, and education skill training action plan as education and skill training, like in our case, like mother is using home stick, and so we can taught the parents to about not to avoid home stick, and in our patients no pets, that is good. After that, we will review the patient symptoms, observations, and side effects, if any, having lung function test, or other comorbidities, and parent satisfactions. Asthma. Should I proceed, sir? Treatment.
So, Arun, what you are talking is for regular asthma management.
Okay,
Here
sir.
we are talking about acute exacerbation. So, how we are going to manage the patient, your patient, that you discuss first, and then you can go through your slides.
Okay, sir. And the in acute exacerbation asthma, sir, initially we will manage the airway, breathing, and circulation, or we will see any of the drowsiness, confusions, and silent chest is present, as you already told. If there is no silent chest, as in our case, we will try it further, clinical status according to features. In mild or moderate asthma, child is talking in phrases, prefers sitting position, increased respiratory rate, pulse rate is 100 to 200, or short acting beta agonist using or not, or O2 maintain saturation 94 or 98, or is he taking oral corticosteroids. And if child is, apart from that, if child is talking in words, this as our patient talks in words, sits hutched forward position, agitated, respiration rate greater than 30 per minute, using accessory muscles, pulse rate is greater than 120, saturation is less than 90%, or if child is O2 is not maintaining, or child is maintaining saturation between 94 to 98%, as in our case, or child is oral or IV corticosteroids or IV terbutaline. If the all ask, if continuous deterioration, we will treat as severity and reassess for ICU if necessary transfer.
One second, Arun. So I'm just asking how you are going to manage this child. Already we have come to a conclusion that this child is a severe exacerbation of asthma. So how you are going to manage this child? So this child has come to ER. So how you are going to proceed? And you have made a diagnosis, assessed and made a diagnosis that this is severe exacerbation. So how you are going to proceed?
So I will proceed my by first of all, the first step, I will give oxygen therapy to child. Then I will nebulize the child with salbutamol 0.15 mg per kg every 20 minutes for over 1 hour. And then I will check for the saturation and child condition. And if child condition is not improving, I will nebulize the child with ipratropium bromide every 20 minutes. Then first over, then 2 to 4 hours. Then again I will assess and I will give the per oral prednisolone 2 mg per kg or IV hydrocortisone 15 to 100 milligram per mg per dose. And then I will reassess the child. If the peak expiratory flow rate is greater than 60, then I will manage accordingly. If the peak expiratory flow rate is less than 60, then I will manage accordingly. And then I will observe for next 3 to 4 hours in the care. If child is responding well and child saturation improved with after that, then I will shift the child in ward. If child condition is not improved, child distress present, peak expiratory rate after bronchodilator, no any increase in flow rate, then I will shift the child to the ICU, sir.
Okay, so here I would like to make a little bit of change. So first you are going to start oxygen and you are going to start nebulization. What is the dose of nebulized salbutamol? For this age, so more than 5 years of age, your dose will be 5 mg of salbutamol for nebulization.
Okay, of terbutaline, yes, sir.
Not terbutaline, salbutamol. 5 mg salbutamol at a 20 minutes interval. Along with that, you will be giving ipratropium bromide also. Ipratropium bromide, what dose will be there? That will be of 500 microgram.
Okay, sir.
So less than 20 kg, 250 microgram, more than 20 kg, 500 microgram of ipratropium bromide. Here in GINA, according to GINA, ipratropium should be given only in first hour of your acute exacerbation. But if you go by British Thoracic Society guideline, so they have written that it should be given in first 2 hours, followed by 4 to 6 hours in initial 24 hours. Then you can stop. So that is little bit of variation in ipratropium. Third thing is you have told that you have to start with inhaled corticosteroids and you have to reassess. Suppose you have reassessed and this child is persistently having distress, his respiratory rate is still persistently 40, but you are able to hear his heart rate has come down. So how you are going to manage this child? Only child is having persistent tachypnea. Rest everything has started coming down. It is not completely normalized, but it has started improving.
Sir, if child is only tachypnea present, then we will decide, we will manage as a good responder. And then I will observe for 3 to 4 hours and continues the short acting SABA with by meter dose inhaler or continuous per oral prednisolone, 1 to 2 mg per kg
No,
per
no,
day.
wait. So here, persistent tachypnea, despite administration of 3 short-acting beta-2 agonist, is considered as lack of response, though there is response in other symptoms. But
Okay, sir.
persistent tachypnea should be taken as lack of response. Okay, and in that case, you have to always escalate the therapy.
Okay, sir. Okay.
So
Okay,
you
sir.
will be continue giving your NAPs or MDIs of short-acting beta-2 agonist, ipratropium, steroids, IV or oral, whichever route you prefer. Along with that, you have to add IV magnesium.
Magnesium sulfate, 40 to 50 mg per kg.
Yes. And
Over
other
20
than
days.
that, you have to give high dose of inhaled corticosteroids. Though you are giving systemic corticosteroids, but still you have to give inhaled corticosteroids in high dose.
Okay, sir.
So what is the high dose of inhaled corticosteroids? When you are giving more than 600 to 800 microgram per kg per 600 to 800 microgram of pressure PMDIs per day, that is called as high dose inhaled corticosteroids. Okay. And then again, you will reassess the child, and depending upon your response, you will escalate or de-escalate the therapy. Suppose now things have settled down. So how you will continue the treatment for this child?
Sir, for the home-based or long
The
management.
same child is in a hospital. You have given IV magnesium, high dose ICS, and now tachypnea has settled. Child is settling down. There is clinical response. So how you are going to manage this child in a hospital setting?
Sir, if child responded well, we will shift the child to the ward, and I will continue the oxygen therapy, and I will continue the prednisolone or oral corticosteroid along with meter dose inhaler, sir.
Okay. And how frequently you are going to give SABA?
Sir, don't know, sir.
Okay. You can give 3 to 4 hourly, 2 to 6 puffs for less than 5 years of age, and 4 to 10 puffs of MDI more than 5 years of age. Okay. And this
Okay,
each
sir.
puff of salbutamol or levolin is of 100 microgram.
Okay, sir.
Okay. And always preferred inhalational therapy is meter dose inhaler. Compared to nebulization, always meter dose inhaler is preferred over nebulization.
Okay, sir.
Go ahead.
Sir. Sir, should I discuss with asthma treatment plan, which has already we will discuss?
No, but we'll come to that. We'll come to that. Now,
Okay, sir.
child is settled. So, how you are going to plan discharge for this child? And how you are going to arrange follow-up for this child?
Sir, we will follow up and the
Discharge.
on the
First, you have to discharge from hospital, then they will come for follow-up. No?
Yeah, sir. And according to that, we will I will regular assessment and monitoring required in this child, and for recognition of extra observations, or is there any minor modification required in control therapy, or is there any requirement of doubling of the inhaled corticosteroids in acute observation for over 1 to 2 weeks, or all patients and in patient must be continued for at least should be followed for every 3 months, and stepping up or stepping down therapy is most important part in case of asthma.
For discharge, you have to see 4 things. First is whatever symptoms child had come with, because you have made a diagnosis of flare-up or exacerbation on the basis of symptoms worsening and lung function worsening. So the symptom should improve symptoms should have improved, and it should be controlled without use of short-acting beta-2 agonist. Okay. Second, there should be improvement in lung function. Whatever your definition was there, that should have been improved. Okay. Third thing is, because you have labeled as a severe, so oxygen saturation should be more than 94% on room air. Okay. And fourth point is there should be adequate resources at home. So there should be written an asthma plan. Parents and patients should be adequately educated. There should be having resources to buy medication, or medication should be available. They should be willing for close follow-up. Okay, so these are all things you have to take care before planning for discharge. And how frequently you will call for follow-up?
Sir, at least every 3 months, sir.
No, first after exacerbation, you have to call them for follow-up after 2 to 7 days.
Okay, sir.
In younger children, within first 2 days only, you have to call for follow-up.
Okay, sir.
Okay, now you go ahead with your slides.
Awesome. And asthma treatment step for children 6 to 11-year-olds. And sir, child. And step 1, and we will either goes by phase 1 or phase 2. First of all, we will assess the child, confirm the diagnosis, and we will symptom control or modifiable risk factor, but including lung function, having comorbidities, and we will take patient preference and goals. And after that, we will we start phase 1 or phase 2 as controller with preferred relievers, track 1, using inhaled corticosteroid relieving as a reliever reduce the risk of exacerbations compared with the using SABAR reliever. And track 2 we will alternatively relievers as before considering a regimens with SABAR relievers, check patient is likely to be adherent with daily control therapy. And we will go step 1 and step 2. If symptom less than 4 to 5 days a week, only needed low dose inhaled corticosteroids are formoterol required, and reliever as a needed a low dose inhaled corticosteroid formoterols. And if symptom most the daytime or waking with asthma once a week or more, then we treat as step 3, low dose maintenance inhaled corticosteroid formoterols. If child has daily symptom or waking with asthma once a week or more and having low lung function, then we will keep the child in a step 4 and treat it as with the medium dose maintenance inhaled corticosteroid formoterols. And if child has short course taking already short course oral corticosteroids may also needed for patient presenting with severe uncontrolled asthma, we will add long LAMA and refer to phenogenic assessments, anti-IgE assessment, IL interleukins 5 assessments, and considering high dose inhaled corticosteroid formoterols. And almost second stage is similar, and in that, yes, sir. Further, I want to discuss the GINA guidelines 2024 and GINA guidelines 2023 differences. Should I proceed, sir?
Yeah, go ahead, go ahead.
In GINA guidelines 2023, there is less detailed as no well highlighted or severely uncontrolled respiratory symptoms. But in 24, these focus on the starting empirical treatment after ruling out alternative diagnosis. Spirometry and peak expiratory flow rate availability is addressed in the GINA guidelines 2024. And diagnostic, according to diagnostic criteria, bronchodilator reversibility is included PF greater than 15%, which was 20% greater than 20% in 2023. Documented expiratory flow limitations removed from diagnostic criteria in table in 2024, which was there at that time. Cough variant asthma's detailed discussion given on bronchial provocation testing, management similar to asthma in general, and which was less detailed on diagnosis and management in GINA guidelines 2023. And on asthma treatment, adolescent track 1, step 1 and step 2 combined evidence is there, which was separately discussed in 2023 guidelines. And criteria to start step 1 is same as step 2, symptom less than twice in 1 month if that was present in the 23 guidelines. Criteria to start step 2 if the in 2024 is symptoms less than 3 to 5 days in a week with normal or mildly reduced lung function. But in 2023, there is no specific cutoff. Symptom if greater than twice a month, but not most days, then we have to start criteria second. And on criteria, start step 3, additional clinical points like exacerbation and airway hyperresponsiveness in 2024. And low lung function without frequent symptoms criteria to start 3 additional points is there in this 2024, but not addressed in the contest considered in 2023. If in children 6 to 11 years, criteria for step 1 is symptom less than 2 days in a week in 2024 GINA guidelines, and symptom is less than twice in a month in the 2023 guidelines. Criteria for step 2 is specific frequency 2 to 5 days in a week in 2024, and symptom greater than twice a month but less than most day. If symptoms are not controlled in step 3, then consider early referral for expert advice. And in 2023, increase the dose of medium dose inhaled corticosteroid, expert opinion if not controlled on medium dose inhaled corticosteroids. And in detail, ICS formoterol device and doses for AIR for allergic immunotherapy provided in separate table in 2024, but not elaborated comprehensively in 2023. An allergic immunotherapy indications may be considered an add-on therapy in selective group of asthmatic children with clinically significant sensitization to aeroallergens after taking account of all pros and cons of allergic immunotherapy, which was not recommended only for adult with allergic rhinitis and house dust mite sensitization in 2023 GINA guidelines. That is the total all changes which were given by in GINA guidelines 2024. Antar,
Okay.
sir?
Yes, Arun. Any questions, any doubts anyone has? I think there are a few questions. First question is how to find inspiratory expiratory ratio clinically for Becker's score. Arun, would you like to answer?
Sir.
Okay, so here you have to first calculate the respiratory rate. So in 1 minute, how many respirations are there? And then you have to find out the inspiratory time for each breath. If you divide, then you will get the events. If you divide respiratory rate, 60 divided by respiratory rate, so you will get how many events are happening. And then if you divide it by inspiratory time, you will get the expiratory ratio. It's a little bit of mathematical calculation. Second question is, why do we give high dose inhaled corticosteroid if we are giving already IV or systemic steroid? So that is because inhaled ICS has got local effect as well, because ultimately asthma is increase the inflammation also. So it acts as a local level, bring down the inflammation. So that is why we have to give inhaled corticosteroids. Third question is Becker's score is used in which age group? So I am exactly not sure, but Becker's group score has so many limitations, so it is not at all used because it just considers your respiratory criteria. It doesn't include the whole examination of a patient. So it is of no much use. And if I'm correct, it is usually used less than 5 years of age. Anything else anyone wants to know? Any questions?
Hello.
Yes, sir.
Hello. I think we can wind up now. And the discussion has gone very well. And if anybody has any question, you can ask.
So I think whatever questions were there in chat box, I have answered that. So
Okay.
I think, sir, we can wind up. Dr. Arun, it was good presentation with your application of knowledge. And thank you. Thank you, everyone.